Thanks, Megan. I appreciate that, and thanks again for all of you that have joined us today for the call. I'm excited about the topic today, which is about the just the outlook for surprise billing, and I think it's a topic it's timely, and it affects so many people, us as individual consumers of healthcare, but for many patients in our practices, or others that we work with, in some way, shape, or form, we are directly or indirectly connected to this topic in many ways. And we're privileged today to have with us Mr. Joseph Mercer. Joe is a managing director at the Marwood Group, and leading their healthcare services and managed care practices at the firm. Prior to joining Marwood, Joe served as a program analyst at the Center for Consumer Information and Insurance Oversight, the CCIIO division at CMS. From his tenure there, he really brings just a tremendous amount of experience in covering government healthcare insurance programs, with a focus on the ACA exchange, Medicare Advantage policy, and issues and catalysts in those programs. As a program analyst at the CCIIO, some of his core responsibilities there included tracking both federal and state legislative and regulatory changes, translating statutory and regulatory requirements into policy, analyzing those provisions of the Affordable Care Act for federal and state regulators, as well as health insurers. Serving as a healthcare insurance rating subject matter experts, collaborating with CCIIO groups and contractors with a focus on working with federally facilitated marketplace development policy. Just a wealth of experience. Joe, as a JD from Washington and Lee University School of Law, and a BA in economics from the College of William and Mary. So we're privileged to have him here with us today. I'm excited to have him and on this subject where he has a depth of expertise. So please welcome me in in having Joe join the group conversation. Joe, to you.
Great. Thank you.
Perfect. Thank you, Steve. And then I would like to mention, as we switch our screens here, if anybody does have any questions for Joe, to please send them in the chat box to Steve, and then Steve can then relay them to Joe throughout the presentation.
Great. Thank you very much, Steve and Megan. So I think a couple of things. I think we wrote that bio before I knew how to say entertaining things about myself, but we'll do fine. The other thing is that as we have a 50-minute time limit, as you'll learn over the next 50, or not time limit, time minimum. As you'll learn over the next 50 minutes, I talk very, very fast. So we will try to slow down as necessary, but I could talk about this stuff for a very, very long time. I've been talking about it more or less nonstop for 3 years, so there's a lot to do. So basically, to set up where we were in July, let's say July, August of 2018, was that you had surprise bills as a thing that states had addressed. I think one of the first ways that states addressed it was California. In their Supreme Court had some issues with it in 2009, I believe, and you saw a rise in state legislation over the next let's say 9 years or so, to the point that the majority of states had some form of protection, which we'll talk about on the next page. But before we get there, I want to talk a little bit about what you get to, what is a balance bill, what is a surprise, and sort of how that all is shaped. So we have 4 scenarios here. the one that, the one I think is important to highlight and carve out is scenario one. Basically, when you say, this is the dermatologist I have in network. There's a dermatologist out of network that I think is the best. I'm going to go to that dermatologist and they're going to take care of me. I know that they're out of network. I know that I'm going to be responsible for greater cost sharing. I know that there's going to be a balanced bill on top of everything else, but I want to go to them. So I'm going to do that. You also have situations where especially in rural areas or areas with fewer providers, that you just don't have, you don't have a specialist in the area. You don't have a specialist in the region. In a lot of cases, health plans will work with you on that, but there's always a situation that you may have to go out of network if you just to gain access. Not really a surprise. Again, you're choosing to go out of network. It's not an ideal scenario, but it's one that was not people weren't looking to address in this in any of these situations. The two scenarios that are going to be at the core of everything else we're going to talk about for the next 48 minutes or so is first, out-of-network emergency department services. That could be a situation where you live and there's a bunch of different providers. When you're in an ambulance, you can try to tell them where you're going, but you may be unconscious. You may just be saying, "Take me to the emergency room." You go and they're out of network. You could also be on vacation. You go to the emergency room, they're out of network, and therefore that's a big source of surprise bills is where you don't really have a choice. And the ambulance takes you there, or a friend takes you there, you end up in the emergency room, they turn out to be out of network. If the hospital's in network, if the hospital's not out of network, it doesn't really matter. The last one we want to talk about is one that I think really brought this issue to the forefront for Congress. Obviously, the emergency department issue is a big one, but one thing that I think really captured the conversation is around when let's say you schedule a surgery, you pick you know who your cardiologist is, you pick a cardiologist who's in network. It turns out though that the anesthesiologist, who you're never going to talk to, right, or the pathologist, who you're never going to talk to, is out of network. And so you go to the cardiologist, that's all taken care of. And you get a bill that goes more towards the surprise element because you had no ability to choose that provider. So those are the two issues we talk about here. I think this was and I'll get ahead of myself for a few seconds here. In the winter of 2019, Congress, as they were shaping these issues, made a shift. They stopped talking about balance billing because that could apply to all these other pieces that you see on the screen. And they started talking about surprise billing, specifically the cases where a beneficiary or a patient did nothing wrong and they were still on the hook for additional costs outside of what their plan would pay. So, I think that there's a lot of conversation. I think that if you're a provider and you look back and you say, you know what, I think that we're mostly in network. We don't think that we are doing a lot of surprise billing. I think one thing that kind of came out was that there was, at one time there had been a lot of surprise bills. There had been a lot of out-of-network providers in the emergency department space, in the ancillary provider space as well. If you look at some of the data that you've seen around it, a lot of it came from 2016 and 2017. And I don't want to name names. I listened to some of your intros. I don't know how much overlap there is here, but if you look at the large outsourced physician staffing companies that were kind of at the center of this because they were because there was a focus from healthcare economists sitting in DC saying private equity is ruining America, et cetera, et cetera, et cetera. Making those comments, talking to Democratic members of Congress about that. They were looking at a lot of 2016 data where you had some very large providers that were primarily out of network. And so it's always been a little bit messy as to, especially among the ancillary physicians, the ancillary providers, it's always been a bit of a question. What is the percentage of bills that could be out of network? And I think what you come down to is emergency department services are always going to be a little bit higher, just because, again, you have that element of why would your local payer have a contract with somebody where you're on vacation, right? Or why would they have a contract with everyone and you don't necessarily know, versus some of the other providers, anesthesiologists, pathologists, radiologists, those sorts of providers. I think the numbers at one point were relatively high. There was anesthesiologists that were willing to go out of network for a long time. I think you saw in 2016, 2017, 16% of anesthesiology visits across the country were potentially out of network. That's obviously a very high amount. But I think ultimately what it really came down to was, in a lot of situations, was that there was concern about the rifle shot nature of the issue, where the total amount of out of network billing might be low, the number of providers that are doing a lot of balance billing might be low, but the patients that actually have experienced these bills, they could be on the hook for $5, $10, $15,000 more in some cases, especially in the case of air ambulance. And so it became a bigger issue. I think one comparison you can make here is to some of the drug pricing legislation that goes through. You can say, look, there aren't that many people that have very, very high prescription drug costs, but the ones that do, they're extremely high. It's a similar situation here, and it's been a similar journey for Congress in this situation. The other thing that informed the process from the very start and made for sort of a continued dynamic is, once Congress started talking to, again, the healthcare economists, started talking to the payers, talking to some other stakeholders, one thing that came through was, I mentioned that you had some of these large outsourced providers, others that started to go in network. There was a lot of concern that if you were saying all the time, we're going to stay out of network and we're just going to balance bill and you're going to pay us what you want to pay us because you don't want to antagonize your patients, you don't want to antagonize your employer clients as a TPA or an ASO. If then you say we're going to go in network, what the view was that there was a lot of in-network rates that were at a significant premium to what you might expect if there wasn't the ability to surprise bill. And this is not my opinion necessarily. This is the observation that Congress was provided. I mean, we've done a lot of work around the data here, and it does seem to bear out. But that's just something I think that is worth talking about as we think through here. So to go back, I mentioned a few minutes ago the concept of all of these states taking action. And I think back in 2018, it was something in the range of 26 states or 27 states had some form of surprise billing protection. Now, that really ran the gamut, though. There were states that, like California, Texas, New Jersey, New York. I think New Jersey just passed their legislation in 2018. They had really comprehensive protections where there was a payment mechanism where if you got a surprise bill, you were carved out of the middle, and the payer and the provider, they had to go ahead and they had to go ahead and handle the situation for you. The payer and the provider had to work out a number so that you didn't have to deal with it as a patient. There were that's number 4 here on this slide. There were other situations, though, where other states had some balanced billing protection where you can say that you had a disclosure requirement. For example, you would just be told that it's a surprise bill. So they're saying, like, you could be, this may be out of network. We may not cover everything. Well, that's not, that's helpful for the idea of if you're going to go see the cardiologist that I mentioned before, and the anesthesiologist is out of network, then they tell you that, then you can at least try to make some decisions, but it doesn't protect you if you don't have a lot of other options. The other way you can do things is a hold harmless, where you tell the patient, look, if you realize that this is a surprise bill, we're not going to hold you personally responsible for it. That's pretty good. It's good protection for the patient, though it does leave the payer and the provider uncertain as to how to address the issue without a clear path forward. And then we also mentioned the idea that dispute resolution I talked about before, which can be in some cases you could have dispute resolution that was, and Texas had this initially. A patient could say, look, I don't think I should owe this much money. And eventually Texas expanded it, like other states had, to be able to resolve any disputes between the payer and the provider using a back end process. And then finally, this is related to it because realistically there aren't a lot of bans without having a dispute resolution process. A full ban for an individual suggests that you're going to actually enforce any balance bills or surprise bills being given to a patient. This is in the federal law as well, which we'll talk about in a few minutes. The idea that if you send a balance bill in an inappropriate circumstance, it's a $10,000 fine. Some states have a similar situation. One last thing I want to highlight, and this is going to get into some of the some of the congressional action, because they'll set up where we were in 2018. The one issue you have here is that in the United States, obviously we are familiar with a relatively complex healthcare system, but in the commercial market even, particularly as it regards state action in the commercial insurance market, self-insured employers, which are nationwide about between 58 and 60 something percentage of all commercial lives, they are covered by ERISA, and states are not permitted to. They're very limited in what they can do to regulate those health insurance plans. So what that means is, as I talked on the previous slide about all the state actions and the work the states did, is that you could have the most comprehensive protective surprise billing protection out there. And frankly, again, California, New York, New Jersey, Texas, Georgia, a few others have very, very robust protections. It only goes to those patients in the fully insured markets. So you could have 60% of your commercial payers that have no protections because, again, the state isn't permitted to do it. And I think throughout 2018, what started to happen was a few of the Kaiser, the New York Times did a little bit, but Kaiser Health News and a few others, maybe Health Affairs as well, started talking about all the instances of surprise bills. Sarah Cliff at Kaiser had a surprise bill of the week. And so what that did was it raised the national profile to the extent that Congress started to work on the bill. I would say that in May and June of 2018, I would have told you, I think that the prospects, even with that additional attention, I would have said the prospects of federal surprise billing legislation were relatively low. I would say that was the last time in the entire process that I wasn't the most bullish person in the room on the prospect of federal surprise billing legislation. Happy, I think by the end of 2020, people were maybe thinking I was crazy, saying that it was still going to happen. Lucky enough it did for my personal reputation. But I mean, that was the last time. And so what happened over the summer, I think in our understanding, is that the health insurance lobby went to Congress and started, chatting up in a relatively quiet year before midterms, started chatting up a few interested members. That could be Bill Cassidy, a senator and an ophthalmologist from Louisiana, Senator Maggie Hassan from New Hampshire, who had an interest in it. A few others, Senator Lamar Alexander, who's now retired from Tennessee. He a lot of interest, on his end too, just thinking about it from Tennessee, obviously a very healthcare focused state. Started talking to them about it and saying, look, this is something that negatively impacts patients and makes it hard for us to keep healthcare costs down. Now, that's their line. I'm not going to say that that's, that everything that happens after this is all in good faith, but that at least, from a patient perspective is right. So in September of 2018, you saw the first working draft. Senator Cassidy started talking about how they need to use 125% of usual and customary charges, which at the time, the provider world looked at it and said, this is not acceptable, that we can't use any sort of rate setting approach. This isn't good enough. I think right now, a lot of those providers would give maybe an arm, maybe they're offhand or they're off arm to have something like 125% of usual and customary rates. But that's that's not where we are. And then later that fall, Maggie Hassan came out with an idea of saying, we need to do arbitration. Steve, I don't know if you had a question. You were moving around. I want to make sure there was no questions. Okay.
No, not at all.
Okay,
Joe.
cool.
Please go
Sorry.
ahead.
I'm sure you'll be telling me. I just didn't want to run you over. So all the early days, the early conversations were actually fairly provider friendly. And that again, 125% of usual and customary is, from what we see now, relatively friendly, and an arbitration only process like the one suggested by Maggie Hassan is also really positive for providers compared to something better for payers. What happened in the first half of 2019 was not so positive for providers, and that is that again, we sat down with the top lobbyists for the Federation of American Hospitals at an event we did in December of 2018, and I asked what their goal was, or what their plans were for surprise billing, how they were going to prevent this from being a problem for them, or how they're going to work around the issue and get to a solution. They said, oh yeah, we're still trying to come up with our take on this. The problem they had is that the payers have been involved for a long time, and as I keep mentioning, the healthcare economists already had their views on who was in the wrong here. So in the first 6 months of 2019, Senator Cassidy had a working group, and then Senate Health Chairman Lamar Alexander also was working on a proposal. And one thing that came out in the first half of the year was that if you wanted to take a tough approach to surprise billing, a tough approach to try and save money, you could save a lot of money. And that is when things started to be, you started to get to a tougher place for healthcare providers, even those healthcare providers that were already in network, because what they realized was if you set everything from a surprise billing perspective, all out of network rates, you say, we're going to pay you at the median in network rate for all out of network rates, then that's what you get. No arbitration, no nothing. They realized you would save $25 billion over 10 years, which, I mean, the last year and a half from a congressional perspective, the numbers that Congress has been willing to spend is, I mean, it's been wild and I think necessary. And there's a lot of positives. But if you think about regular order Congress outside of a pandemic, $25 billion is a giant pay for. And so once you had that idea in mind, it was very difficult for the hospitals and other providers to push Lamar Alexander and others having them to like want to go be aggressive, and they weren't convinced that the providers were saying like, we can't make this happen. So the summer goes by, you had some members of Congress that were more doctor friendly, saying we need to include arbitration, we need to have some protection, et cetera, et cetera, et cetera. At the end of 2019, there was an agreement, and it was going in this vehicle that was going to pass Congress at the end of the year. At the very last second, Ways and Means said, we aren't going to be good with this, we can't pass this. And Speaker Pelosi said, you know what? If you guys can't come to an agreement, we're not going to include it. It fell out of the bill. I think a lot of people thought at that point that surprise billing was dead because they spent a whole year on it and nothing happened. In 2019, nothing happened for 2020, nothing happened for a good chunk of the year. Obviously, there was one pretty significant interceding factor there in that you have a pandemic. You had a lot of congressional action, but you didn't have very much going on. The Trump administration was very interested in a surprise billing fix. They were pushing it, which helped get support of regular order rank and file Republicans. But really nothing happened over the course of the year. There were some conversations at the very, very end of the year. Finally, Ways and Means came to the table and said, you know what, we need to have a negotiation-based process. But they were willing to go, and I'll flip to the next slide here. We are going to go ahead and be comfortable with an idea of negotiation followed by binding arbitration. Arbitration was the magic word for providers for, at that point, 2.5 years. Arbitration was the only thing they were going to go with. So to stop telling stories and talk a little bit about policy for a few minutes, let me talk about what this means and what the policy has here. And forgive me, I'm sharing a screen that isn't as cleaned up as the document you guys have. But So what the policy is, as it was passed by Congress in 2020, if you get a surprise bill, so a patient goes to an out-of-network emergency department, what happens is they pay their in-network cost sharing. So they have to, let's say their in-network cost sharing is $200, they pay $200, and then the patient is out of the middle. They don't have any impact at all moving forward. That's, they're all taken care of. What happens then is the payer and the provider. The payer basically has to say, give the provider an estimate. They have to say, we think that this service costs $500. We'll make up some numbers. We think this is going to cost $500. The provider at that point, if they are an out-of-network provider, they're subject to this rule. They can say, all right, well, we are going to accept that, $500, and we can just go along our way. If they don't like that, they have 30 days. They have 30 days to say, we don't like that, to reject it. And after they say that they reject that amount, the payer and the provider have 30 days to negotiate, where they can try to go back and forth and find themselves to a mutually agreeable number to avoid arbitration. If in that 30-day period, they cannot find a rate, they cannot find a mutually agreeable rate, either party can go and select an IDR process, an arbitration process. So again, we get back to this idea of the arbitration, which is the big issue, the big win for providers in this process. The problem for providers, the problem in the way that this is still able to drive savings per the Congressional Budget Office is because once you go to arbitration, it's baseball style arbitration, which means that each party puts in a bid. And the arbitrator is going to look at those bids, and they have to pick between one. They can't pick the middle ground. They can't mess around. They have to pick one of the two bids. The catch here is the qualifying payment amount, which I think we refer to here a lot as a median in-network rate. So what they do to calculate the median in-network rate is that they look at, each insurer has to calculate their own. They say, all right, we're going to look at the geographic region, which is either like each MSA in a state, and then all the rural areas, they're their own MSAs. We're going to look at this region, we're going to look at this insurer, and we're going to look at this item or service. And what was the median in-network rate? You just stack all the rates on top of one another as of January 31st, 2019. So they looked at that. That's the qualifying payment amount. And the way it works in arbitration is the baseline expectation. This was confirmed just earlier today when the second interim final rule implementing the No Surprises Act, to get way ahead of myself, was released. What they do in arbitration is they say, look, what's the qualifying payment amount? We think that's the right amount to pay for an out-of-network service. But we also look to some other categories as well. We're also going to look, and I'm way ahead of my deck, but we'll jump around a little bit. We're going to look at other things to try and get an idea of what the qualifying payment amount is. And I'll talk about those a little later, that it could end up being slightly higher, it could be lower. And the idea behind all of this, and the idea that makes providers nervous, the reason that you had congressional advocates for the providers, for the hospitals, nervous about all of this, is that at the end of the day, the concern is this doesn't necessarily just impact out-of-network providers, right? Like, it's not as simple as here are a lot of out-of-network providers. These are the bad guys. We're going to force them to come down to these in-network rates. The concern is that insurers are going to look and say, man, we've been paying anesthesiologists 3 times what we've these anesthesiologists over here, we've been paying them 3 times what we pay some of the other guys, but we've been paying them in network, right? So we've contracted with them the last 4 years, but their rates are still very high for one reason or another. And so the reason that that's a concern, the reason that that's a problem for the providers is they say, we already made the contract. Now what we're afraid of is the insurer is going to come in and say, all right, here are all of our premium rates that we're paying above the median. We're going to kick all of those guys out of network. We're going to force them to then come in and negotiate with us, and then go to arbitration where they're going to get subject to the qualifying payment amount. That's the reason for all the contracting. That's the reason for all the concern is that, yeah, we talk to people. I'm sure you all know providers that have stayed out of network, that have never been interested in going in network, that will certainly be impacted. But the concern across the board has been what happens to those in-network providers. So I had somebody ask me today, what percentage of bills could conceivably be left open or be involved here? And it's like, well, yeah, here are the surprise bills, right? It's probably under 10% of all bills include a surprise bill, or 10% of all spending, well under 10% of all spending in the United States involves a surprise bill. But because you have this dynamic, this qualified payment amount dynamic, the concern is that it's going to drive down those rates for in-network providers. And we get into this now, I realize belatedly on slide 7 gets into it a little bit more. The idea is, again, this is what's going to happen. Now, there's a few different things that I think can happen to mitigate that. And there's a few things that it's not necessarily like the worst thing in the world for providers. And I'm coming at it from a very provider-centric angle. For a payer, there's a lot of things going on as well. For various different vendors, there are things going on as well to try and help both providers and payers manage through this. So it's not just providers, but I think that they're the most directly impacted. They're who the savings are coming from, which is why I focus on that. A few things that are mitigants. The first thing that's a mitigant is that the rate is tied to January 31st, 2019. The reason that that's important is that one concern throughout the process was if you don't have an anchor time frame for when the median network rate happens, it means it can be massaged downward by plans, right? Because if your median network updates every year, what you do as an insurer, if you're trying to save money, is you take your 5 most highly reimbursed providers every year, you kick them out of network. Now your median network goes down and down and down, right? There's actually some fear right now that that's happening in California because California passed a surprise billing law that relies on the average in-network rate, but doesn't tie to an anchor. And the view is if you're a highly reimbursed provider in California, you've already been kicked out of network and invited in at a much lower rate to try and massage down those rates. In this case, there was a level of protection against that because it's anchored to January 31st, 2019, and it's updated every year by CPIU, which in most years is just fine. Arguably in 2022, it actually could be pretty good if some of the inflation concerns are borne out through the whole year. But regardless, it's something where there is going to be a rate that is going to go up over time by CPIU every year. The second important piece, the second potential mitigant for providers is that plans still do have network adequacy requirements. They do still have to cover a certain number of providers in a given region. And also there's a few steps in the process, right? There's a couple different bites at the apple if you're a provider. If the plan doesn't want to play ball, if they kick you out of their network, you still can go in. They're probably going to allow you an opportunity to negotiate. So you go in and negotiate with the plan on the front end and say, we think our rate should be 1,000. They say we think it should be 500. If you're that far apart, you're probably not going to come to an agreement. Maybe you say, all right, well, we've always been at 1,000 before. We're fine with 700. And the plan says, okay, we'll do that. But let's say that doesn't happen. Now you're out of network. You start having these bills come through. These out-of-network bills come through. You now have a second chance to negotiate. So now you can negotiate after the bills come through. You have a second chance. Now you're saying, look, we really want 700. We don't have to go to arbitration. 700 is still what we want. The plan might say, you know what, it's not worth the uncertainty. We'll go. And then the third piece of the puzzle is, especially for 2022 and maybe into 2023, I expect there's going to be a fair amount of uncertainty as to how the arbitrator will decide on many of these different pieces. And so we'll talk about that in a few minutes as we swing back around to the rule that came out earlier today. But those are some of the mitigating factors. I think the other thing about it though is that in many cases, the providers who have had higher reimbursement rates over time are likely providers that have better market share. They're likely providers that have at least been considered to have higher quality, and they may be tied to hospitals that the payer really wants to have in network. So not alienating those hospitals or not alienating their providers or forcing the hospitals to have to pay a higher stipend or something else like that to better support these outsourced physicians or the anesthesiologists, the radiologists in their facilities. There's reasons that you might say, you know what, we are paying you 200% of the median. We'll pay you 150% of the median because we want to keep you on our network and we don't want to have a problem. Obviously, if you've just purchased a business or you're trying to maintain a certain margin profile, that's not great. But compared to going all the way down to the median, it's something I think that that is more manageable. And we don't see a lot of situations where providers are at 200% of the median. I think in many cases it's 130, 140% of the median. So if you're at 120%, it's not as significant than these wild numbers I'm just making up on the spot because I want to have an easier time doing math. So that's something that is something to consider, is it may not come down all the way. So this law passed in December of 2020 in the Consolidated Appropriations Act. It's the No Surprises Act passed it passed in December, and the statutory deadlines were the qualifying payment amount that you had to go into place. You had to regulate around that by July 1st, 2021. And then the IDR process, the arbitration process, had to be regulated by October 1st, 2021. So I keep making reference to the rule that just came out. Tomorrow is October 1st. So just before we got on this call, HHS and the Department of Labor released the new rule, which I was able to read a few pages of before I came on today. So if you ask me about page 475, I haven't gotten there yet, but I think we can probably manage through if there are questions about what we have today. A lot of what you see on slide 9 is not especially interesting unless you, I'm happy to answer any deeper questions. I think the key points is that, HHS and the Department of Labor, at least in this initial process, they tried to, I think they tried to be as even-handed as possible. They tried to do some of the things that make a difference, or the size of the geographic area. I think there was a concern, for example, that your geographic area would be the entire state. So if you're in New York and you're a provider in New York City versus somewhere in the the westernmost part of the state, you may have a very significant difference in how much your typical provider rates are, and have some concerns that if you have to roll back and be dealt with on that level, that's going to be a problem. And so, as I mentioned before, the way that they did geographic regions they take all the metropolitan statistical areas, and each metropolitan statistical area in a state is its own region. So New York City can be itself. I don't know if Albany counts as MSA. Albany can be itself. Buffalo can be itself. And then the rural parts of the state all count as one. And so that's a situation. One thing that's interesting, and I think will be interesting for certain provider types, is the way that they had the threshold for finding a median network rate. So if you remember, I talked about having each insurer calculates their own median network rate. So you can imagine in some cases, let's say you have it earlier in the deck, on my screen, we talked about IO&M, which is interoperative neuromonitoring. That's a specialty where there's virtually nobody in network. Everyone's at a network in that entire space. And one question we've got around that particular space is, well, what if they can't find enough providers that to calculate a median network rate? Well, this is a place where HHS said you only need 3 to calculate, to calculate a median network rate, which is a little bit of a concern to certain provider types. Again, like IO&M, air ambulance is one where there's very few in-network providers, and you can have some concerns where if you don't have a lot, or you have very few, that's probably not good for providers, because the ones who have gone in network are oftentimes going to be reimbursed at a much lower level. For the folks that have all tried to stay out, the reason they stayed out is they can get very high reimbursement rates in an out-of-network setting. And so therefore having to go in is a problem. What happens if you don't have 3, you don't have sufficient in-network rates? What you have, what you're going to deal with is you're going to look to various different databases and other things to get an idea of what the rate is. That's actually a pretty good situation for a provider in most cases. The payer is going to have to manage through that. Other things, again, not really a whole lot else that is talked about here. I mentioned, this is a little bit more. Okay, let's skip ahead for a minute. One thing I wanted to talk about, because I do think it is pretty important here, because it's really the next most important thing. We talked a lot about the arbitration process. And this is what CMS said earlier today. They said, the most important factor, the first thing you look at is that median and network rate and qualified payment amount. So the arbitrator is going to say, this is the appropriate rate. But then you have these other pieces that are in place, and you have them here on this slide. The first one is level of training, experience, quality, and outcomes. I think the idea here is that if you are a provider that has demonstrated high quality, it may be that there are specific outcomes you come to. It may be that you've been a center for excellence or something else. There's been some other recognition of your quality at the state or federal level. That's something that's worth considering. The market share of both the payer and the provider. I think this is interesting, where you can say, look, in a certain area, this can cut both ways. In a certain area, if you have, let's just go to Alabama, right? Blue Cross Blue Shield of Alabama has something like 95% market share in their commercial market in Alabama. It's giant. You have to work with them, or else you're not going to be able to be in network with anyone. That's a situation where if a provider has still managed to have premium rates, I think there's an argument to be made that there's a reason that they do that, right? Like that's important that you've done that. Whereas in certain areas, in a more fragmented payer environment, but let's say you have an out of network or a very powerful outsourced physician group, where let's say somebody owns all the anesthesiologists or employs all the anesthesiologists in Dallas. And the payer has to work with them because they need to have somebody in network from an anesthesiology perspective. That's going to come through as well to say, well, are these rates really based on quality? Are they really applicable? Or is this something where the market share had an undue influence on the in-network rates? One issue, I think, acuity of the individual or complexity of the service. One trouble you have with this, I think providers were excited about this, at least at first. The problem you have is that because arbitration is always going to be done on a given item or service, you can't really say, like, this is a really hard surgery, right? And because it's going to be compared with all these other similarly hard surgeries. However, obviously, if you have complicating factors, obesity, other conditions, time constraints, something else like that, those are factors that could weigh in. Again, complexity of service, not again, outside of those factors, it's going to be difficult. One thing I wanted to highlight, though, and I think this is pretty important, is demonstrations of good faith efforts to enter into network contracts or prior contracted rates from prior 4 years. This goes back, and I think this is going to be a very valuable piece for providers who are trying to keep their premium rates or trying to stay higher. Because as I mentioned, over the last 5 or 6 years, the percentage of overall providers that have gone in network has increased significantly. And because the reason that's important is, again, unless you have a situation going back up to market share of the payer and the provider where there is an overwhelming market share on one side or the other, you've contracted for these rates. And so it's going to be very difficult to say, well, we contracted before, they've now kicked us out of network. How are we supposed to do this? There's I think there was a comedy show years ago. He said, I didn't want to be in public. You put me in public. It's the same thing. I didn't want to be out of network. You put me out of network. So now to say that we need to go to this median in-network rate for out-of-network services, this is a very powerful piece of the puzzle. And I think that it's going to lead to a significant amount of uncertainty in the arbitration process, meaning that providers may see higher reimbursement rates throughout 2022 and into 2023 than maybe they'll have later in the process, depending on how the arbitration process, works. So those are a bunch of really key considerations, and that'll be the most important thing coming out of the rule that came out earlier. A few other things I wanted to talk about that I think are really important here. I mentioned that the insurers are responsible for calculating their qualifying payment amounts. I think the reason you did this is that the insurers obviously have all their own data. No one else has all that data. I don't know if you've ever tried to use a publicly available database for commercial data. it's not a really great scenario. It's, there are some databases that are really good, some that aren't very good. I think one example is in Texas. Again, I listened to most of the bios, not all of them. Texas uses the Fair Health database, which is a fine database, but one that tries to lean on bill charges in many cases and goes and forces things up. So what Congress, CMS, or HHS, they don't want to have to deal with that. So they told the insurers, you need to calculate it based on these very specific principles. The problem you have here, and this is the problem that was highlighted by the providers throughout the process from a lobbying perspective, is that it sort of assumes that health insurers are like the selfless stewards of American healthcare, that they're just here to try and make sure that they're going to be a selfless referee in the process. And I think there's a lot of concerns about that. So this is something that has not really come up yet in the conversation. Now, there's a process that HHS put in place where a provider can say, look, I think that qualifying payment amount is wrong. You need to tell me how you came up with it, and we need to go and get it audited by CMS. So that process is going to be in place, but you can imagine you have, thousands and thousands and thousands of items and services. You have thousands of providers. You have hundreds of insurers. There's a lot of complexity here, and everyone's going to be mad all the time for the first few months of this process. And I think that's something that's also really important to consider, is that there's going to be, before you even get to the arbitration process, there's going to be countless challenges. And I want to bring up a little bit of a conversation from earlier in 2021 to sort of highlight that. Earlier this year, United Healthcare kicked Team Health out of its network for a few services. They said, we want to renegotiate our contracts. Again, I don't know whose toes I'm stepping on in the room, but here we are. They said, you need to get out, you're out of our network. And they said that Team Health had emergency department contracts that were 3 times the median network rate. We've done a lot of work in the space. I'd be very surprised if there was actually any contracts that United signed of their own accord that was 3 times their own median and network rate. And so that's the sort of distrust that's been sowed throughout this process. And I don't know what United's data said. I don't know what those contracts were all about. But there's, those sorts of numbers are going to be very difficult for folks to swallow if the median network rates come out wildly different. One other thing I wanted to talk about is, and this is going way, way back to earlier in the deck, I talked about the state balance billing approaches. One thing that the No Surprises Act allowed for, they allowed the state approaches to stay in place if the state wants. Now, I mentioned as well that ERISA does not allow the state to regulate self-insured employers besides in very, very narrow ways. So what this does in many states, and what it will do for January 1st, 2022 and beyond, it'll create a 2-track process in some of these states, which I think will be very interesting for a couple of reasons. One, almost every state process is more generous to providers and harder on payers than the federal process. The only exception is probably California, which I talked about before with the sinking average of the average in network rate. So what it means is that if you are a provider, your fully insured rates in New York may end up being quite a bit higher than your self-insured rates. And so I think that's going to create a dynamic. There's not much that providers can really do, but it creates an interesting dynamic with lobbying at the state level, where payers are going to lobby. I think in many cases, the insurers are going to lobby and say, look, let's just all go to the federal side. Let's not make this complicated process. Burdens are what burdens are. We don't want to make employers, we don't want employers to have to pay too much money for healthcare. So let's go ahead and just go to the federal process, which will lower costs even further. Whereas the providers are going to say, we need this to stay open. We want to make sure that we have this extra dynamic. So I think that'll be a very interesting dynamic as you get a little bit further on some of those future lobbying efforts. And frankly, in some states, Texas, for example, I think has a lower percentage of self-insured employers employees than other states do. I think it's like 55% fully insured, 45% self-insured, as opposed to 60-40 in favor of self-insured we've seen in other places. And so I think those types of things for a given provider in a given region will be interesting. So I want to we have a few more minutes, but I want to make sure that, we got our last polling question in, but also if there are any questions, if people do have any questions before we wrap up in a few minutes, I wanted to shift and talk about a few other things that are going on that were in the surprise billing, that the bill that I think are going to be important. So I think what I was gonna highlight first is around price transparency. So you may have seen earlier this year some conversation. The Trump administration promulgated regulations requiring hospitals to post all of their negotiated rates. That was implemented as of January 1st, 2021. Compliance has been relatively low. I think that's because the penalties were low and hospitals don't want to pay to have somebody just put their business out there. The Trump administration also finalized a transparency and coverage rule in late 2020 that required health insurers, including self-insured employers, to post all of their rates. So the hospitals just had to post their rates. Then if they had outsourced folks coming in, they didn't have to post them. Payers, as of July 1st, 2022 now, every single negotiated rate they have has to go up on the internet. Every single allowed charge and billed charge for all of their providers has to go up on the internet. And then the payers also have to come up with self-service price comparison tools for 500 services for January 1st, 2023, and all services for January 1st, 2024. And I think that it's important to consider these price transparency efforts in conjunction with the No Surprises Act. Obviously, you can see how the No Surprises Act it's going to ramp up sort of animosity between the payers and providers, but also carve patients out of the middle, create a little bit of a better environment for patients. But I do think that there's going to be a shift with providers having a lot more information as to what their competitors are making, a lot of other dynamics with competition and some of the vendors in the space being able to say, look, here's how you can save. If you're a lab company, are you in the hospital? Are you out of the hospital, right? If you are a radiologist, do you want to go and focus more on out of the hospital versus in-hospital radiology? Something that's going to shake things up a little bit from the in-hospital, out-of-hospital dynamics. And the other thing I think that'll be interesting in this space is that, and a little bit of a hurdle for providers, if I'm being honest, is it also requires for all scheduled services that providers put together a good faith estimate of what their services are going to be. So literally every single scheduled service, as of some point in the future, when they actually regulate around it, every single service that is scheduled, they have to send a good faith estimate of what their charges are going to be to the insurer, and the insurer has to tell the individual, this is how much it's going to cost you. It's a significant increase in the regulatory structure and the requirements for providers and payers. It is something that, as we talked about surprise billing, as that's dominated the headlines, I think it's something that's been a pretty significant. It's a pretty significant change in how things are going to be done. And so all this put together really shifts how people are going to think about how people are going to think about healthcare information, how the provider-payer dynamics are going to go, and frankly, how some of the provider-provider dynamics are going to go, with an increase in attention to how much other providers in given areas are going to be paid, different payment arrangements that they're having. A lot of what has otherwise been considered contractually protected information or other things, those things are going to become a lot more public. And the shift is probably not going to be 2023 or 2024, but the shift is coming, and 2025 and beyond. That may be as much of an upset to what's happening from a healthcare perspective as anything else. So I want to make sure that I am hitting my time numbers, but also make sure I'm not forgetting anything else. But that's really what we've come to here. It's a lot of information. I try to talk slower. If you can imagine, this is slow. And so I think that obviously it's a lot. I skipped over some of the weedier stuff, but happy to answer any other questions now. Otherwise, I'll turn it over back to Steve.
Yeah, Joe, gosh, thank you so much for that. That was a lot of information. The complexity inside of all this is significant, and you did a wonderful job in pulling that all together and summarizing it in a way that we could consume. And I really appreciate that. I'll open it up with a question and then maybe turn it over to members of the group for others. It seems like all of what's happening here is going to largely put a tremendous amount of pressure on the provider community, especially to contain their costs. And I'm curious, just if you envision all of this, hastening in some way consolidation and industry consolidation in certain sectors of healthcare. I'm thinking right now about those typical out-of-network groups. You talked about team health, but the emergency medicine space, anesthesiology, radiology, even hospitals in a broad context, where they're already operating on thin margins, might be sort of hastened to combine. I'm curious about your vision for that, and if you would anticipate the private equity capital that's sitting on the sidelines being invested to drive consolidation here.
Yeah, well, I mean, it doesn't seem like there's any slowdown in private equity considerations around consolidation in these businesses. One thing I'm a little concerned about is a lot of the positives, a lot of the reason for consolidation that's led to some of these things has been the fact that you can get higher market share and you could do better, right? You can be bigger and therefore drive higher rates. That if you are comfortable with the rates you have, if you feel comfortable that you have controlled costs, that you may be less receptive to an acquisition or something else like that as a physician group, knowing or looking to see, is team cutting rates or anything else like that. So I think that's a dynamic. But yeah, I mean, I think all roads lead to consolidation. And this wasn't the topic of the discussion. But one thing to be aware of is that the FTC is looking into physician practice consolidation right now, trying to put together a playbook to do a better job of looking into those that consolidation. I don't think it's it's going to be the end of consolidation in the industry, but right now a lot of those practice acquisitions fall below the FTC's radar. So I think there's a little bit of a countervailing force already starting to spin up, and that you're going to continue to see consolidation. Continue to see that, but a little more concern around that, and the concern that you can get bigger and bigger and bigger, and that may not help your rate situation as much as it would in the past.
There's a question from the group that came in, and we talked a lot about different fields of medicine, and the question came in about dental, and if any of this is expected to have an impact on the dental industry at all.
It's really not. Dentists are they're not generally going to be in here. And the reason that they're not going to be included here, there's a variety of reasons, but one thing that's important is that there just aren't as many situations in a dental environment where, and I'm not an operator in the space, so I'm not as good as some other people are here, but there's fewer situations in my mind where a dental practice is so large that you have a separate anesthesiologist, you have separate, there's just fewer situations where you have this out-of-network provider in an in-network facility. There's other things that may impact the dental space. If you expanded the Medicare benefit to include dental, for example, which is in conversation in Congress right now, I think that would have an impact on dental. But from a surprise billing perspective, I haven't looked at it as being much of a factor.
Got it, thank you. We might have time for one more question. If someone would like to raise their hand or chime in here for one last question before we wrap up for the night. Chris?
Yeah, thank you. Thanks. I really enjoyed your presentation. And by the way, I did not work for Team Health. So I'm curious, there's always been sort of a tension, a three-pronged tension between patients receiving the bills and paying the insurance companies paying the remainder of the bill, and the providers. Always kind of this tension between provider, patient, and insurer on payments and all that. How do you see some of this changing over time as companies like United with Optum start to integrate into providing healthcare?
Yeah, I mean, obviously the surprise billing rules are gonna, reduce a lot of the concerns, at least for a certain subset of bills with that tension, right? You have the processes resolved in two different areas. But I do think that it'll be the network dynamics are something that's going to come up. And I think what you've highlighted is where you're going to have network dynamic issues in the future, where if you have United acquiring tremendous numbers of physicians, how hard is it going to be in areas if you're not an Optum physician to get in their network in areas where they're going to have to deal with it. And I think that that's the next conversation. And the question is going to be, are there going to be regions where doctors are put in a negative position? I don't think we're there yet, but I do think that's something that providers talked a lot about over the course of this bill, and it wasn't quite ripe for conversation, at least in Congress's mind. But this is the next step, and I think that's going to lead the conversation on the next steps here. When providers say, "Oh no, we're doing really bad right now because of the way this worked out." That coming back to Congress and saying we need to look at network adequacy, we need to look at the vertical integration components of that and how you can build vertical integration like sort of guardrails into network adequacy. And I think that that's a conversation for a few years down the line, but that's the way I think that it's going to be addressed, is looking at the vertical integration to understand how some of these network decisions are being made and whether they're being made in good faith.
Thank you.
Great, thanks. Great question, Chris and Joe. Thank you. I know we're up on time at 6. We're at the top of the hour, and Joe, I just want to thank you again for just a great job for taking all this time with our group and lending your expertise and time here. It's been really enlightening and educational, and we really appreciate it. I'm going to just turn it back to Ashley or Megan to wrap it up.
Perfect. Thank you, Steve. Joe, thank you again for the program and speaking today. Very insightful. We will be sending out a thank you email to all the attendees. So if, maybe you don't have any questions right now, but if something pops up later, feel free to reach out and then we can get those questions sent over to Joe. Steve, thank you for moderating. And of course, everybody, thank you for joining us. Really hope that you enjoyed the program. Our next event will be for the healthcare SIG will be Tuesday, November 9th. So keep an eye out for an email invitation for that. We also post on LinkedIn quite a bit whenever we have new events. So stay tuned for that. And we hope everybody has a great evening.
Yeah, good session. Thank you, everybody.
Yep. Thank
Perfect.
you.
Thank you all.
Thank
Have a
you
great
all
night.
very much.
Bye-bye.
Bye.